Good afternoon and welcome to everybody. It is a great pleasure for me to share this session with Francesco Maisano that you all really well know. So this session is dedicated on the management of patients with multiple structural heart disease to treat and how to best approach a combined strategy. So the session will be based on clinical cases, and we're going to discuss these cases and trying to illustrate what could be the benefits of certain devices, like for example the Portico device, the Amulet, or the MitraClip, because we have now a large portfolio of devices available for structural heart disease, and it's really time to understand how to manage the patient and how we perform the procedures. So you can see that it's a quite small room, and that is perfectly fitted to this type of session. Feel free to interrupt and most importantly interact. You have microphones on the side. Feel free to ask any kind of questions, comments. We have two experts here with Francesco to answer any kind of questions you may have. So the first case will be presented by Lars Sundergaard from Copenhagen, and it's a patient with bi-valvular disease.
Thanks, Tchétché. Yeah, so this talk is about how to treat a patient with aortic stenosis and mitral regurgitation. Should it be as a concomitant procedures or as a staged procedures? So this is my conflict of interest. So the patient is a 67-year-old gentleman. He's in function class 3. He got severe aortic stenosis, opening area 0.5 square centimeters, very poor LV function, 20% in ejection fraction. His mean gradient is not very high, 32 millimeter mercury, probably due to a low flow, low gradient. But during a dobutamine stress, we could see that his LV function went slightly up, and also the mean gradient increased to 55 millimeter mercury. At the same time, he had at least a moderate functional mitral regurgitation. He's been on hemodialysis for several years. He had ischemic heart disease, had in the past CABG. All the grafts was patent, and he was in atrial fibrillation. So this is his transthoracic echo as part of the workup. You can see heavily calcified aortic valve. LV function is for sure impaired. And his dobutamine stretch, which brought his peak gradient, as I said before, from 32 to 55 millimeter mercury. And we knew that he had some degree of mitral regurgitation. His posterior mitral leaflet was a bit short, a bit restricted in motion, and continued to do a transesophageal echo. We could see there was at least a moderate mitral regurgitation based on this PML. So we discussed it in the heart team, and there was an agreement to proceed to do a TAVI procedure. I don't know about you, Francisco and Gigi. Is that he's a candidate for TAVI, or is anything which should turn him down for TAVI?
So I think it's a high-risk patient. So in principle, is a patient that qualifies for TAVI. Still remains a discussion about durability of a tissue valve in a hemodialysis patient. But I would not be too much concerned about this decision at this moment. I think TAVI is without discussion. I think the topic is what to do with the mitral.
Yeah. And what about you, Didier? Would he be qualified for a TAVI procedure in Toulouse?
Yeah, definitely. This is a clear candidate for TAVI, but for sure it's extreme risk patients with such a low LVEF. To my opinion, I hope that you're going to be fortunate and not be forced to treat the mitral, because with such a low LVEF, with the MitraClip, sometimes the regurgitation is necessary for the patient, and we've seen patients with extremely low LVEF that are not performing well after the MitraClip. So in the ideal scenario, I would go only for the transcatheter aortic valve implantation for this patient. and then see what's going on with the mitral. I had only one question. Did you experience any change in the degree of regurgitation during the dobutamine stress echo?
To be honest, we didn't look for that. Would that help you? Because you say the next question is, we discussed during the heart team meeting, should we, on the top of the TAVI, do a MitraClip procedure? Or what do you think? What would...
So the first question is, we have seen some images where the AMR was not so critical. So probably what you say makes sense also to make a test. The other question is, when do you assess MR? This is a patient with hemodialysis, so according to the loading condition, you can have a huge difference in MR. Did you see also in this case, did you watch the AMR before and after the dialysis?
We only had this one shot, transesophageal echo, and to be honest, I don't know where it was in between his dialysis.
But this, I think, is an important thing to look at when you have patients with dialysis. MR can be very variable according to the loading conditions. So we have seen a lot of patients having a reduction of MR after the treatment. And now, in our own practice, this is a typical functional MR. There is calcification of the annulus of the posterior leaflet. The anterior leaflet is also a little bit more, maybe a bit fibrotic, but still there is no flail. There is a restricted motion of posterior leaflet. It is a patient which may improve after TAVI. So in such a condition, I would rather think about eventually a stage approach. I will start with TAVI first. What did you...
You agree? Did you stage?
Yeah, in such a patient, if the LVEF was better, I would have certainly done everything during the same procedure. There is something that we could discuss in that patient because the LVEF is extremely low. It's a high-risk patient, hemodialysis, and so on. Did you consider balloon valvuloplasty just to see how the left ventricle behaves, how the mitral regurgitation behaves before going for TAVI or MitraClip?
I mean, the patient was very symptomatic. He was in function class 3, and he got severe aortic stenosis, and he had a contractile reserve. We saw that on dobutamine creating went up. So for us, there was a clear indication to proceed to do at least the TAVI procedure. So we didn't take into consideration to do a balloon first and then reassess how to do it. It's also about how you do your setup. Are you going to plan for a TAVI procedure in local anesthesia? Are you going to do a combined procedure where you need general anesthesia and so on?
So maybe we can ask you from the audience. If anybody would like to, in this patient, do concomitant, TAVI and mitral?
Raise your hand.
Raise your hand if you want to do both. Nobody is raising the hand. So either they all messaging or nobody agrees with the concomitant. Who do only TAVI? All right, so not much messaging going on. That's good. So consensus in the audience is to go for TAVI only.
Okay. So I think if you want to do concomitant procedure, not only in this case, but in general, there's several things you have to take into consideration. What degree of extra burden do we add to the patient? It's going to be a longer procedure, additional radiation. It may take different contrast, which in some patients could lead to renal failure. And that had to be to balance of the benefit of the patient to have it a combined procedure. I think if you do a TAVI procedure and a MitraClip, you don't use additional contrast after the TAVI procedure for the MitraClip, so that's not an issue. And also the duration is relatively little for the MitraClip. So I don't think in this case the additional burden for the patient is not stopping you for doing a combined procedure. Second thing you should take into consideration is the use of resources. Is that reasonable? And as I said before, most institutions will set up for a TAVI in a quite simple way. In local anesthesia, patient may go straight back to the ward. But if you want to do a combined procedure, the patient needs to go into general anesthesia. It'll take more patients, more people in the room, and you may need an ICU bed after the procedure. And also, there should be a fair balance between what the patients prefer and the expenses for the institution. So even though most patients may ask for a one-stop treatment, a combined procedure is not reimbursed. The institution will, most places, only be paid for one of the procedures, so they're going to lose money of doing a combined procedure. This may, of course, be changed if this can a normal practice to do combined procedure, and also if it's agree and have acceptance in the community. And also, maybe most important in this case, the indication for the second intervention should still exist after the first procedure. And if you look into patient who's undergoing TAVI, how many patients got a mitral regurgitation at baseline? So you can see if you look at patients who have a moderate or severe regurgitation, we're talking about 15 to 20% of the patient. And if you look at a patient who have a severe mitral regurgitation, it's somewhere between 5 and 10%. And it's for sure have an impact on the outcome of the patient. So if the patient going in to a TAVI procedure with a significant mitral regurgitation, which is not addressed, there's an odds ratio for mortality in 30 days of 1.5. So about 50% higher mortality rate if you don't address that. And you can also split it up to what kind of mitral regurgitation. This is a number of studies, and if you look on your right-hand side, it's about 50% of the patients who have a functional mitral regurgitation and 50% who have an organic mitral regurgitation, saying that there will be an overlap. Some of the patients will have both a degree of functional and organic mitral regurgitation. And then you can, maybe most important, you can look what is the chance if you do a TAVI procedure that the mitral regurgitation is going to improve. And it's about 50% of the patient who's going to have less mitral regurgitation after the procedure. And then it's a question, of course, can we try to identify the patient who's going to have less mitral regurgitation after the TAVI? And there's several studies looking into that, and in the bottom I have just summarized what is coming out. Patients who have a low ejection fraction have a chance to have an improve of mitral regurgitation after TAVI procedure. Same if it's at a functional mitral regurgitation, if the patient is not in atrial fibrillation or have not pulmonary hypertension. So the patient I just presented is fulfilling the low ejection fraction and a functional mitral regurgitation, which is a predictor that the mitral regurgitation is going to improve. On the other hand, the patient actually got atrial fibrillation, and we have no information about his pulmonary hypertension. So in this case, there was a decision, as we discussed, that there's a fair chance that the mitral regurgitation is going to improve afterwards because it's a functional mitral regurgitation. LV function is severely impaired, and therefore we planned for a stage procedure. And again, if you want to do a stage procedure, you should do your TAVI procedure first, and then afterwards discuss the indication to proceed to do a mitral clip at a later stage. So this was the plan for this patient. The patient had an uneventful TAVI procedure. There was almost none paravalvular leak in this, no need for pacemaker. And he came back 6 months later, still in function class 3, and he had an echocardiography showing a well-functioned TAVI valve. There was no sign of any paravalvular leak in this transesophageal echo. And also, if you look on his mitral valve, the mitral regurgitation for sure was not less than it was before. It was at least a moderate mitral regurgitation, and you may even argue in this functional mitral regurgitation it would be classified as a severe mitral regurgitation.
Is it truly functional? Sorry.
Could you go back?
Yeah, we have seen a chordal rupture. Yeah, good point.
What's your concern?
No,
Well, we see a chordal rupture.
You can understand the evolution that it doesn't improve at all, and now you need to fix it. I mean, it won't improve even with medication.
I agree to see something up there, but I mean, what I have seen at all the echoes, I haven't seen any. It looks like a functional mitral regurgitation. But again, you can have a point, and as I said before, also there can be a mix of functional and degenerative mitral regurgitation. And for sure, this patient did not improve.
But I've seen other cases like this where for the manipulations we do in the left ventricle, we
With
may
the
rupture a
wire.
corda with the wire.
Could
This
be.
can
Could
happen.
be doing the TAVI procedure.
These patients are,
Yeah.
anyhow, they have a very fragile system, under tension. The cords in a non-degenerative valve can be very thin. So you may have this kind of problems and have worsening of MR. This can happen.
And I have one additional comment for you, Lars. Did you experience an improvement in the left ventricular ejection fraction 6 months later? Because the MR seems worse than it was 6 months ago.
Yeah. LV function did not improve. It was still
So-
about 20% despite of the TAVI procedure.
Which is quite disappointing.
Yeah,
after
it was
the TAVI
disappointing, yeah.
procedure.
And I have to say, it's important for the audience to clarify, this is not a typical behavior. Most of these patients improve, but as you show now, there is also possibility that patients do not improve, even worsen, which is pretty rare in a functional MR, but this can happen. Maybe there is a concomitant problem. You know, this function, you know, sometimes I think we need to think about these patients. They are not per se aortic stenosis patients. These are heart failure patients. Therefore, they can also undergo fluctuation in LV function and MR status. So we have to a little bit change the way we look at these patients. These are more heart failure than valvular patients, or a combination of both.
So the decision in the heart team was to bring the patient back for a mitral clip procedure, and he had a successful procedure. He only had one clip, A2 to P2, and only have a mild mitral regurgitation after the clipping, and a low gradient about 1 millimeter mercury. So at 3 months follow-up, he was in function class 1 to 2. He had a mild mitral regurgitation, but still LV function was impaired, still running about 20% on echo. So just in conclusion, as I see it, if you want to consider concomitant procedures for TAVI and mitral clip, you have to make a decision whether it's an acceptable burden for the patient, radiation contrast. I think that's both fulfilled in a mitral clip case, and also the use of resources, anesthesia, ICU beds, and so on. And here you can argue if you do it in local anesthesia, your TAVI procedure, it requires more resources to do a combined procedure. And the big question is indication for mitral clip still existing after your TAVI procedure. And again, you have some predictors who can help you to make the decision, but often it's uncertain how it's going to react. In this case, we thought there was a chance that it was going to improve, and maybe it even got worse. And then finally, what is the balance of cost for the institution and what the patients prefer? And for the time being, most institutions, if not all, you don't have a combined reimbursement for 2 procedures, so the institution is going to lose money, which of course should not necessarily stop us for doing combined procedure in the future, but then we have to change the reimbursement system.
Thank you, Lars.
So stay there because
Stay with us, yeah.
we discussed a little bit. So let me start from the very end of your presentation. Some countries have already a special reimbursement. In Germany, there is a reimbursement for concomitant procedures, which I believe it makes sense because, again, it's in favor of patient to some extent. If it is a good indication, the patient should come only once to the hospital. Now, let me ask you, if you do a concomitant procedure, how do you do it? You start with mitral clip and you do TAVI, or you do TAVI and then mitral clip in the same setting?
In the same setting, I think we have done very few. We've done a TAVI procedure first, and I think that may be most important because if you get rid of the mitral aortic stenosis, the patient will tolerate fluctuation in the hemodynamic. And you know, during the mitral procedure, even though we treat patients with very, very poor LV function sometimes, they're rock stable during the procedure. You don't see the same fluctuation in hemodynamic as you see for the TAVI. So I think for a safety point of view, it's probably better to address the aortic stenosis before you go to the mitral valve.
Yeah, not only think about, this is typical. I think you should always treat the downstream lesion first. You know, aorta is after. You know, this is a concept in surgery. The similar concept is coarctation and aortic stenosis. You would start with coarctation. Anyhow, the other thing is it's probably also easier to grasp the leaflets properly if you resolve the afterload. So it may, in a functional MR like this case, where there is a little coaptation, you may be helped by that.
Yeah.
We do the same?
Yeah. So for the concomitant procedures that we did, there were two concerns. The first concern was about the anticoagulation, because as you did and as you recommended, we start with the aortic valve just to reduce the afterload and to make sure that the hemodynamics is really well appreciated before going for the mitral procedure. But then you need to provide heparin to the patient. And so what we do is to provide minimal amount of heparin and to go as fast as we can for the aortic valve, to flush the shifts regularly, to avoid to start the transeptal puncture with an ACT of 300 something, because even if we are accurate, more and more accurate in puncturing the septum in the appropriate location, from time to time you may do it twice, 3 times, and it may be harmful for the patient. So that's what we do. We start with a minimal dose of heparin, and then we readjust once the septum has been crossed. Another, so you may comment on that, Francesco.
I do a bit different. So let's stay on this very initial step. I think it makes sense. So we also have been very concerned about this thing. What we do, actually, we do transeptal puncture first. We leave a peak there in the left atrium, and then we do the TAVI procedure.
That's very wise. And do you do it with the Baileys?
No,
just
it's
to
not,
have safety? Or
it's not so important. No, we do it as usual. We do a regular transeptal puncture. We use the regular SL0, whatever, whatever transeptal system. But we learned this for safety, not only for the transeptal. I like to really have all the access done. Even the venous puncture, sometimes we know that. Sometimes you don't get the vein, you screw up, you make an hematoma. So it's nice to start your access first. We do the TAVI procedure, and after, which is, by the way, nice because you have LA pressure through all the procedures, so you can monitor the status. Then we end up TAVI. I like to close one chapter, so we close the access, and then we proceed with the mitral clip.
Okay, and the over concern is about the skill set that you need to do to achieve such a procedure. So from what I understand, we are all experienced operators, so we are able to do both procedures. But maybe in the vast majority of the centers, there will be TAVI operators and mitral clip operators. Do you think that a modern interventional cardiologist or surgeon should be able to achieve and to perform both procedures? Or do you think that it's wise to dedicate 2 different persons and that will require an upgrade in the organization to make sure that both persons are present at the same time? Or do you think it's preferable to have one person, one operator, being able to do both procedures?
I mean, this is a very political question, and it's addressed very different from side to side. But I can see that structural heart disease is increasing, and what you're going to see a new generation of interventionists who's only doing structural heart disease 5 days a week, and I think those people are going to master all kind of it. But what you see today, quite a few people are doing surgery, doing some catheter interventions, doing PCI, doing some catheter interventions. So it's a bit mixture. So today you'll see a more heterogeneous field of people doing a structural heart disease. But again, as I say, in a few years, you see the next generation will come out and be trained specific to do structural interventions, as I see it.
But they will suffer.
And then I'll be Francesco.
No. I'm saying, it's a short blanket. I mean, if somebody does only structure, if you have a PCI patient, a patient who requires complex PCI at time of TAVI would be a problem as well. I mean, it's anyhow. I think it's very variable. I am totally with you that we need to be more focused. Yeah. I'm the first one to advocate focusing. On the other hand, focusing requires also be able to sometimes say, okay, I need help from somebody who has more experience than I have. So if I have to do I can do primary PCI, no problem. But if I have a TAVI patient who requires also PCI, I never do it alone. So I believe in somehow building a team around the service, and for some specific cases to be in a couple is not a big deal. It's a good thing.
Very last question for you, Lars. The choice of the device, the TAVI device, at the start of the procedure. Did you discuss about using a balloon expandable device or a self-expanding, or the type of a self-expanding device that you were
I
going
mean,
to use?
this case was actually a few years back, and at that time we only used self-expanding devices in our institution. Today we had a more broad portfolio. It's hard to say. If you should argue anyway, in this case, patient have severe LV dysfunction, he got at least a moderate mitral regurgitation, you may choose a valve which have as little impact on the hemodynamic, a valve where you don't need to pace, where you don't see a drop in blood pressure. I think that will be, if you want to play it safe, it could be, of course, a Portico valve or similar valves.
Yeah, you can discuss this a lot. I mean, no valve is perfect here. Balloon expandable valve, they need rapid pacing.
There's some of them.
Portico, you need
The balloon
predilation.
is, yeah.
And core valve, you have this obstruction of flow. So actually, there is no perfect valve in this field. I think what we do, for instance, let's focus on Portico. We're very happy with Portico, providing that you implant it well. This patient will not be very happy with residual AI. So you need, what we do, we use to predilate without rapid pacing using a kind of nucleus or V8 balloon. We try to do this without rapid pacing in very low ejection fraction. And then we use Portico pretty successfully.
Yeah. I guess that the LVEF is really one of the element to consider when you select your valve choice. And also the risk of pacing for this patient, because with a depressed LVEF, maybe you want to avoid an additional pacemaker at the end of the procedure and free interventional things, and that's why maybe it's not industry really driven, but a Portico device or a device with the minimal rate of pacing is a good choice. Okay, that was a great discussion, great case, Lars. Thank you very much. And
so should I introduce the second? The second discussion is even more, I mean, a daily discussion. There is a lot of politics behind this, I think. It's a never-ending story in our institution, combining LA occlusion and other structural interventions. So we'll see this case now.
Thank you, Francesco, for the introduction. So I think I have to click here.
Yeah, sorry, I didn't introduce you, Dr. Azzamendi
Sorry.
from Barcelona. Sorry.
It was a little joke. Thank you now, Francesco, for the introduction. So the thing is that I'm gonna give the talk about the question that they put to me is is there any future for LA occlusion therapy in atrial fibrillation patients indicated for TAVI? So the first thing I think we need to remember is that almost 30% of patients referred for TAVI, they have prior atrial fibrillation, and almost another 10 to 15% will develop atrial fibrillation after TAVI. So at the end, we have almost 40% of patients with atrial fibrillation after TAVI. And in all the studies and registries, atrial fibrillation has shown to be a predictor of mortality on TAVI patients. In this study, you can see how the Kaplan-Meier curves, the patients with atrial fibrillation did much worse in terms of mortality, in long-term mortality, compared to those who were in sinus rhythm. Moreover, if we check the multi-order analysis, we can see how new-onset atrial fibrillation and even baseline atrial fibrillation were the most strongest predictors of mortality on patients on TAVI, with TAVI. We might think that this mortality is related to stroke or to severe events, but if you check for that, you can realize that there is no significant differences in many studies about the stroke rate, or comparing patients with sinus rhythm and atrial fibrillation, and this might be related mainly because patients on atrial fibrillation, they're under medical therapy. However, what we know is that on TAVI patients, bleeding has been an issue, and bleeding has shown to increase dramatically the mortality of patients, of TAVI patients. And the thing is that if we check which are the predictors of bleeding on TAVI patients, atrial fibrillation is one of them. So we may assume that this mortality may be related to the bleeding, and this may be related to the medical therapy. So if we have to answer the question, is there any future for occlusion patients referred for TAVI, I think the answer is clear, is yes, because probably if we're able to read them off of the medical therapy, we might even have an impact in their survival. The second question is, how can we plan this procedure? So I think we have many different ways to do it. I'm going to start with a safe way. So I think this is a standard way, or this is the regular way to do it. probably we should do it with echo guidance, transthoracic transesophageal echo. In this case, obviously, at least in Spain, you need to put them on general anesthesia. And the thing is that the good thing of that is that you can recheck everything at the moment. You can check your aortic valve to check if there is an issue there. You can also take a look to your appendage, see that there is not any clot. So before starting the procedure, you already have some information and some reassurance, and you know that there is no danger on going ahead with the procedure. Obviously, the TOE is a really good imaging technique to do your transeptal puncture. And you can see here clearly with the explained view that we are inferior and posterior and we have a good puncture there. So as Francesco said, we do the same strategy. What we do is we put the sheath first, we do the transeptal puncture, we put the sheath there with a line. So we are giving fluid through the line all the time so we don't get any clot through the sheath. And after that, we go for the TAVI implant. I think, and we are getting used to do it, yes, with fluoroscopy, but echo is always good. I mean, in this case, you can see the deployment, and you can see clearly your stent that is not interfering with the mitral valve, that is not deep. And the thing is that you can clearly check that you are putting your valve in the right spot. Moreover, you can check immediately the result. You can see that there is no surprise, that the regurgitation is mild, and you already know you don't need even to give contrast. So I think this is a good point for doing the procedure under TOE. And once you finish with your TAVI and you close the access, you can go for the appendage. You do your angiograms. You can see clearly also in the echo how you are doing the injection. And after that, you can put your device, and you can see perfectly how it's fitting just over the circumflex with a good result. And after that, you are all set. So which are the advantages of doing it in the safe way, guided by TOE? So I think it's there, as I said, the reassurance. You can reassess the case just at the moment. You have a continuous monitoring of the patient. You have an early detection of a complication. I think this is the gold standard still for LA closure. And there is a thing about price, because we're going to talk about other technology that are a bit more expensive. The drawbacks is that you, as I said, you probably need general anesthesia or at least deep sedation. You need an experienced echocardiographer, and there are some of the complications related to TOE that we can't forget. The other way to do TAVI and LA closure, it's the all myself, or probably I can call it also the cowboy way, that is trying to do it all alone. So you can guide the procedure all alone by using the eyes. So the good thing is that if you get experience, the eyes is really good to check also your transeptal puncture. You can see here, it's this like kind of a bicaval view. You can see that here clearly we are inferior and we are doing the puncture. And the second good thing is that once you put your sheath there, you have really nice views of the LVOT with the sheath into the ventricle. So here you can see this will be the regular view. But with the eyes, you can go deep in the ventricle and you can bend it, so you can see all the whole outflow tract from the beginning till the ascending aorta. So this is a really nice view to check how your device, how your valve is sitting there. So we put a Portico also here, and you can see perfectly that the valve on the eyes, you can see how it's well set. It's in the right position, right spot, no interference with the mitral. The valve is clearly not deep at all, so you can deploy it completely. And it's not just the angio. You are completely sure that the deployment is perfect, because you can check it also with echo. And you can check also your final result, as we did with the TOE. You can do a short axis, you can check for leaks, and you can see here the result is good, so you can finish with that and go for the LA closure. For the LA, and my suggestion is that and we've tried many positions with the eyes, and I have to say the best one is going to the left atrium. And here, if you go between the left atrium and the mitral valve, you bend your eyes probe, and you have really nice pictures. You can see perfectly how your device is setting there. I think we don't find even differences with the TOE, and you can do the procedure safely. So the advantages of this way is that you have a continuous monitoring. There is no need for general anesthesia, and you don't need an echocardiographer with you. The drawbacks is that there is a learning curve. Obviously, you have to be trained on eyes. And the problem is also it's multitask. So you are deploying a valve, you are checking the imaging. So there are many things. And there are some complications related to the vein access, obviously. And the other issue is the price. I think here I want to show a short thing. Yes, about the multitask thing. This is a case that we did. And as you see, we are doing that, and we didn't realize that since we were doing many things together, we didn't realize that there was a perforation there. You can see the contrast going to the pericardium. So we didn't realize the patient crashed, and finally we were able to drain the pericardium, and there was a problem because it was the co-prof who perforated the appendage, so patient finally needed surgery. He did well, but I have to say sometimes you appreciate that you have other eyes taking care of you and giving you some help. And finally, we have a third way to do it. We can call maybe the geek way to do TAVI and LA closure. This is probably using the navigators. I think echo and heart navigators, they're amazing things for structural procedures here. You can see how the echo guy is pointing where is the pass of the aortic stenosis. He's putting the pointer in the fluoroscopy, and we are following him, and the wire goes exactly where he pointed we have to go, so you just need to follow him. You feel a bit stupid because he's telling you what to do all the time. So here also you can see perfectly, you are not just seeing the calcium of the valve, you're seeing the leaflets. So while you're doing the deployment of the valve, you can see perfectly that your valve is just below the leaflets. You can see that you can reassess that the position is good. And I think this is the best and the safest way to do the procedure. Moreover, in this case, we decided to go for appendage closure after the TAVI implant. So we are finding the safest way to do the transeptal. So he puts a pointer also in the septum. It goes to the fluoroscopy. You just need to follow it. You go to the pointer, and you're exactly in the right spot to do the transeptal puncture. And even if you want to guide how your pigtail is going to the appendage, you can see clearly here that the pigtail is going through the appendage. You can see the circumflex, and while you're deploying your device, you can see that you are putting it perfectly in the right position, and you don't need to be rechecking in two different screens. You are seeing all in the same screen. In terms of the heart navigator, it has other advantages. You can use it also for the femoral puncture, because you can use the navigator as a road mapping. So you can do the puncture with heart navigator, and you can use also to alienate your sinus, and you can find the best projection for the TAVI implant and to go through. Moreover, it's pretty good and reliable for the transeptal puncture because the septum is not moving at all. So in this case, they put a pointer, and we are just in the right spot also for the transeptal puncture. So it's a pretty good option also. And you can see the appendage perfectly there. So after that, you can cannulate and do the procedure. So the advantages of this way to do is that you have a simultaneous view in the same screen. I think you can guide perfectly every step in a really safe way. You get a lot of information. There's an increase of safety. And I think mainly for teaching purposes, for follow training, I think this is a good tool. The drawbacks is that you need, obviously, the system. There is a learning curve. And one of the advantages at the same time that the drawback is there is a lot of information. So at the end, you have to trust in one of the screens. So sometimes it can get a bit messy. But I think you can get used to that, and obviously the price. So in conclusion, I think LAO closure has to be considered on patients with atrial fibrillation and contraindication for WAC, referred for TAVI. I think both procedures can be safely in the same procedure because you need general anesthesia in most of the cases, so it's better if you can do it just once. And I think current imaging modalities allow us to tailor procedures to the patient and to the operators. So thank you.
So let me just start with some criticism and put all the audience against you. Who likes this fusion imaging? Who wants it? So good. 4 people. It's not bad. It's coming. So let me tell you. We can discuss fusion image. It looks like geek. In 5 years, everybody will have it. So it's not discussed. You should not even discuss it. Whether it is useful or not at the moment, there are some cases where it can be very useful. Some other cases are still a kind of a experimental thing. Let me go back to the very basic, because we're talking about combining procedures. And you focus on TAVI and LA occlusion. And you made very straight point, yes, it is useful. Now, let me challenge this. Having said that, I have been the first who believe that we should be doing it. But when I discuss this with referring cardiologists, I get a lot of different opinions. So opinion number one, there is no evidence that you can improve outcomes by LA occlusion in AFib patients. where is the evidence for LA in occlusion in TAVI patients with AFib? This is the first question. We don't go into this. Let me say, a patient who has atrial fibrillation requires anticoagulation. Maybe is, latest evidence is supporting anticoagulation in TAVI patients to prevent leaflet thrombosis.
That's right. That's why I remarked that this should be considered in patients with contraindication to anticoagulation. I think the rationale of doing both procedures together is if the patient doesn't tolerate any kind of antithrombotic therapy, and if you do the both procedures together, you will shorten the length of the therapy. And this makes sense because if you do the TAVI first and you wait for the later, you will need 3 months for dual antiplatelet therapy for the TAVI, and after that, you need to do appendage, and you have to prolong your dual antiplatelet therapy. At least in our own experience, we have a lot of patients with GI bleeding. They don't really do well with dual antiplatelet therapy. So that's the rationale of doing the both procedures together. But I totally agree. If the patient can't tolerate all anticoagulation, I have my concerns of doing this procedure.
Lars, you are...
You could argue there's no reason not to close the left atrial appendage. Why did the patient go for a bioprosthetic aortic valve
replacement
to avoid anticoagulation? So if you leave the AFib and need for anticoagulation, what have you gained giving the patient a bioprosthetic aortic valve with a limited durability?
Yeah, I agree with your point, but I'm gonna put the devil point now.
So
the thing is that
I don't understand the question. Can you state your statement is we should close all of them?
Otherwise, you haven't gained anything about giving the patient a bioprosthetic valve.
Yeah, just to be clear, I wanted. So the message is, let's prevent. And I tell you, most patients, you describe the procedure, blah blah blah. At the end, you say, we can close the appendage. And you don't need anticoagulation anymore. And then, thank you. This is the most important message to this patient. Although,
but there are also reimbursement issues.
But not just that.
But that is an important fact.
The patient will. There is first the indication. What is the indication for LA occlusion? Contraindication to anticoagulation in a patient in atrial fibrillation.
Exactly.
And there is another.
This is the first indication. So we have sometimes at one point we have to stick to the some rules.
I'm just saying that this is an emerging indication for sure, and there is also some concern about combining therapies. In theory, we have been doing for many years triple therapy in these patients with AFib and TAVI. Now we don't do it anymore, but it is a problem.
I can just say now in France, in the US, it's opposite. The indication is for patients who can actually go on anticoagulation.
Yeah, that's true.
And not for the patient.
So it's the opposite. So we have to wait for this type of indication to improve in.
But we should measure also how much does the second procedure increase the risk of the patient. So this is something we don't know. I mean, even the better operation has some grade of complications. So it's a patient who comes from aortic stenosis. You already did a tough procedure. Maybe you have some vascular issues. After that, you go for another second procedure. So we need to know which is the risk of the procedure itself. Because from the surgeons, we've already learned that doing more than one valve surgery increases the risk of mortality. So we should measure also that for combined procedures. Because I showed the case. I mean, you look a simple case, and we perforate, and the patient finally finished on the OR.
But wait a second, don't confound the problem with the solutions. I mean, if the patient with double valve surgery have a higher risk because they have two valve disease.
Yeah, I know.
So it's not that combining and the stage procedure is basically twice the risk. You have two times the risk of a procedure. So this has to be addressed by a study. I agree with you. But it doesn't mean that combining procedure per se is more risk than doing only one procedure. You should not always close your eyes.
It's not doing one. It's doing or not doing on patients that don't have contraindication.
No, I agree with you.
Okay. So having said that, we've seen that you've nicely demonstrated that it's feasible. It's easily feasible. It seems to be safe for the patient. But you've demonstrated various ways of achieving that. How do you create a hierarchy among all these possibilities? What is your standard technique? What are your indications for providing such or such technique to such or such patients? Or what are the contraindications? Do you have in mind the contrast amount that you're going to, the amount of contrast that you're going to use for the patient? What are the key elements that you consider to select one, this technique or another one?
So the thing is that TOE and the navigators go together. It's, if you have it, it's the same procedure. So I think is that since we do CT to all the patients for TAVI, you can use the heart navigator for a lot of things. I think this is a good point. And I personally, and as Francesco said at the beginning, you have to get used to, but if you have an imaging guy who takes care of that, there is a lot of potential. It helps a lot, it gives you a lot of information, and I think you can improve even your result and your safety. The fact is, so if you have to check, the thing is, that which is the choice, ICE or TOE? And when we use ICE, it's mainly when we don't want to intubate the patient. So patients with lung disease and difficult intubation, we think that for whatever reason, we think that it's not going to be good to intubate the patient. On those cases, we go for ICE. And indeed, you can combine also ICE with heart navigator because, as I said, you have the CT, you put the navigator, you can have also some markers that might help you with the procedure. Because with the ICE, the only problem is that, at least from my point of view, there is a long learning curve.
Learning curve, yeah.
So, David, let me a bit elaborate on your assumption about all by myself cowboy, which is, you know, when you do things a bit advanced, usually it's good that you define yourself cowboy so nobody tells you are a cowboy. I've seen the technique of ICE-guided LA occlusion. You have two devices through the septum, so you have double puncture.
Yeah. That's right.
Do you do double puncture or you go with parallel wires?
No, we do double puncture.
Double puncture.
Because I was, you know, I don't know. I've seen many guys, they do really wonderful things at dilating this, doing one transeptal, dilating the septum, and after that trying to put your ICE probe through the hole. Listen, I'm not able, I haven't been able to do that. So the rationale of doing double transeptal is that also your sheath is more free, so we won't move while you are doing your LA occlusion. Because if you put all together while you are doing the rotation, at the moment that you want to check the probe is out and it's looking to another point. So that's the reason why we do the double puncture. And the truth is that if you have the reference from the first sheath, it's easy. You just follow it. You go just a bit below and you can do a second puncture safely.
So you puncture below the first.
That's right. You guide with imaging the first puncture, and the truth is that second one we just use the sheath as a reference to the second puncture.
The other question is the sequence. I would like to know better. So the sequence of LA occlusion at TAVI starts with puncture.
That's
transeptal puncture first.
Axis, probe
axis. Also venous axis.
Venous
and arterial axis.
That's right. We got all the axes as you say. We see exactly as you say. We do all the axes. We get the double proglide. We do the transeptal, and once we got the transeptal, we gave the heparin. We put the sheath. We put the TAVI, and we get the TAVI in the case you are using ICE. You go through the sheath, because the truth is that the images for the LVOT, they're the nicest one, they're taken from the left side. And since you have to do the transeptal, you take advantage to guide the procedure directly from the left. So we find out that this was good, and since you already had done the transeptal, you put the sheath there and you can check everything.
Can I ask the audience, who is able to do TAVI here? Who does TAVI?
Raise your hand.
Who does LA occlusion? Who does both? So this is one challenge here, and I mean, in many institutions there is a TAVI expert, there is a LA occlusion expert, there is a mitral hip expert again, and how you foresee the future here? How often we will combine procedures according to skills?
So I think, as we said, obviously there is a future in all these procedures, and we need to train the people. And as I said, I think in these cases, and the navigator systems are really useful, because when we learn to do the transeptal, we use just fluoroscopy, but it's difficult to explain to someone. The reference is just because the X-ray. Instead, if you have a marker and you can check why it's there, it's easier to teach and it's easier to get people involved. I'm pretty sure if you tell someone where he has to put the catheter, even anyone who never has done a transeptal puncture will learn doing that.
And to foster this evolution, in my opinion, what do you think we need a trial?
I think we do.
Abbott?
I think we do. I mean, I'm serious. I think we do, because we have a lot of patients on atrial fibrillation that come from TAVI. A lot of patients. And our feeling is that we are tempted to do on patients, as we said, without contraindication to allow anticoagulation, and you don't do it just because reimbursement, you don't do it because you say if the tolerates, just continue with anticoagulation, but you are really tempted to close the appendage.
Let me just, another question. I have a lot of questions. We are in TAVI, but let me ask you a mitral clip. If you have a patient AFib doing mitral clip, what do you do?
To close appendage or close it?
The same.
All patients or only only patients with contraindications?
What would the question? I will put the question to you as your experience as cardiac surgeon. What would you have done if you are in the operation room?
Well, I tell you, this is a very highly debated topic. On the other hand, I can tell you there is much more. It's much more reasonable in the mitral space than in the aortic. You are already there. Transeptal is done. You are in front of the appendage. You should close it. Also because MR protects from embolization.
Mm-hmm.
You know, you see after reduction of MR, a lot of patients develop smoke sign.
Mm-hmm.
And in my practice, I believe that every patient with AFib with a good anatomy should close the appendage, just like I do with surgery. It is not guided by therapy. And again, please, I hope that Abbott will invest some efforts here to support this indication, because I believe it is good for patients.
Mm-hmm.
Okay.
Totally agree.
So maybe one last question for you. Do you have the follow-up of your patients? I'm asking that because we can imagine that if you go with 2 punctures of the septum, from time to time you may end with some kind of significant defect. So what is the proportion of ASD closure?
It's French.
You do
really.
free
Mitral clip 24. Once in a while you have a small ASD without
We've
French.
seen
You don't
We've
have
seen
anything.
that in some live cases.
Yeah, but it's not frequent. I mean, we don't do routine TOE, but we do TTE, and we don't see any significant ASD. And normally they do it really well. There is no issue with that. And as I say, even with the mitral clip patients, it's weird. The cases that they still have a significant ASD. Normally, the ones that have significant ASD are the ones that you didn't got a good result with the mitral clip. You have a still residual MR, and that's the reason you have a still flow from the left to the right.
Okay.
So let me ask you another question. You know, we have to make it longer.
If you have any comments, please feel free. Yeah.
We have, you showed us also, you have a pretty strong background in imaging. So if you want to address our colleagues and say what is the most important additional skill which is needed for developing this field forward, you think what is more important to learn about the details of the procedures, to implement the skills in imaging? What is the first step?
I think my feeling is that from the teaching point of view, the first thing you need to know is about the devices. So I think, and my feeling has been that our echo guy has learned from us about the devices, and we have learned from him about imaging, but you need to know how the devices behave before you go ahead. So I think this is the first step. And after that, I think it makes sense, mainly for fellows, to send them at least 3-4 months to the imaging lab so they can learn CT and TOE. I think it's really useful. I mean, I think you get a lot of teaching there.
So I think I have slides on session evaluation, which is standard for PCR. Before I go into this, I would like to ask the audience if you have burning questions. Yeah, I mean, we are in a field with some. We are very initial stage of this procedure. You have technical questions, even asking what kind of tools are we using, for these procedures. It is the right time to do it. If you have no questions, then we have to close the session with my session evaluation.
Thank you.
So. So, what did we learn here? I have a very one slide. So, I think the first message that we probably agree, everybody agrees here, that you should really consider to close the appendage in those patients undergoing TAVI procedures with contraindication to oral anticoagulations. This is somehow, although it's not a specifically guideline-oriented approach, it is conform to guidelines because it is a patient with contraindications for anticoagulations. This can be done There are some challenges in terms of logistics, in terms of planning, in terms of skills. My suggestion is that if you do TAVI, you can't afford not to learn how to implant the LA occluder. And so really get this additional skill, because it is needed in a larger proportion of patients. I mean, there are several patients undergoing TAVI as AFib. I strongly believe that there is room for expanding indications in those patients, as Lars just told us. Avoidance of anticoagulation has a strong role in quality of life of patients. Anyhow, we need to demonstrate that this is a feasible approach, and unfortunately, there is not yet a reasonable trial design for this kind of approach. We also had some discussion about combining TAVI and MitraClip. We have seen a case of functional MR which didn't respond as usual to therapy. Most patients have a reduction in MR. We have seen a case where this didn't happen, which I think lesson learned is that you really have to follow up these patients, particularly if it is a patient with low ejection fraction, having in mind that this field of TAVI is in the borderline zone with heart failure, just like MitraClip. And so we have seen that in this particular case, this has been a staged approach. Anyhow, we also discussed a combined MitraClip and TAVI in the same setting is feasible in selected patients. It is also clear that in case of functional MR, there is a chance of MR reductions. Therefore, the stage approach is better than concomitant. TAVI should be performed first. Although, again, in many discussions, there are some physicians who believe different. This is our belief. There is no standardized opinion here at this time, but it makes sense in a combined setting to treat the afterload first before you treat the mitral valve. And at the end, the last one, I took this take-home message from an email from Lars, which I really believe is a really central question here. Patients like to come once to the hospital. They don't like to come twice, okay? It is just like, Fabian Nilsbach has this slide showing the rationale to do things at the same time, which is if you bring your car to a car shop and the guy tells you, yeah, you come the first time you can replace your tires, then you come back in 1 month, you will clean the car, and then you have to come back another time to make your revision. You will probably don't go to this car shop anymore. You change your dealer. So patient would like to have things fixed in one session when it is indicated. Obviously, this has to be kind of balanced with the challenges in our institution. In our own practice, we decided to lose money on selected cases just to give an overall better service to our patients. So patients who require combined procedure like aortic stenosis and degenerative MR, they get one-step combined procedure, although we lose money in these kind of cases. But I think at the end of the day, patient first is our objective. With this, you want to say something?
No, I just want to congratulate you. We are perfectly on time. Congratulate all the speakers. And so the next session is a symposium on transcatheter mitral valve replacement and repair. What's the future? Sponsored by Abbott. So I thank you all for your attendance, and I wish you an excellent meeting for the rest of the day. Bye-bye.